from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about aortic aneurysms. Our guest today is Dr. Kristen Walker, a cardiovascular surgeon here at Sarasota Memorial. Dr. Walker, thanks for being with us again.
Thanks for having me.
To revisit a topic we've discussed in the past, what exactly is an aortic aneurysm?
So it's a very specific definition. An aortic aneurysm is any vessel that's more than 1.5 times the diameter of normal. So when we're talking about the ascending aorta, which is what I specialize in, the ascending aorta's normal diameter is between 2.5 and 3.5 centimeters. So if I take the middle of that, 3 centimeters, multiply it by 1.5 to get an aneurysm, anything bigger than 4.5 centimeters is considered an aneurysm of the ascending aorta.
And what about an aortic root aneurysm? Is that different?
No, yes and no. So the aortic root is the very first part of the ascending aorta. So when we talk about the aorta, there's technically 4 different sections. The root is the very first part it starts at the heart, and it contains the arteries that feed the muscle of your heart, your coronary arteries. It also contains the aortic valve, which is the last check valve in your heart that keeps blood going the right direction out of your heart. So that's the aortic root. It's kind of a bulbous shaped anatomic feature. And then after the root, you have the ascending aorta. It's called the ascending aorta because it ascends in your chest. And then at the top of your breastbone, it makes a turn from the front to back, forming an arch. So we call that the aortic arch. That's where you get the branches to your head and your arms. And then it becomes your descending aorta. Once it makes your turn, the arch from front to back, it runs along your spine, where it's the descending aorta that goes down to your abdomen eventually and gives off the branches to your intestines and finally your legs.
So an aortic root aneurysm is specifically in that root instead of in the ascending
very
aorta.
First part of the ascending aorta.
Got it. What risk factors are associated with developing an aneurysm in the aorta or the aortic root?
When we're talking about the abdominal aorta, smoking is probably the biggest risk factor. In the ascending aorta, uncontrolled hypertension and genetics really play a big role.
And what are the risks associated with an aneurysm?
As the aneurysm grows, as your aorta grows, that aortic valve can be pulled apart. So those leaflets, instead of coming together like this, come together like this, and they allow blood to leak back into the heart, which can lead to heart failure. You also, as the aorta gets bigger, the wall gets thinner and it gets weaker, and you can develop a tear in that wall if your blood pressure is really high. That's called an aortic dissection. If you develop an aortic dissection in the first part of your aorta, it's a surgical emergency that we have to take you to the operating room as soon as you present to the hospital because it's highly lethal.
If someone has an aneurysm, is it ever recommended to leave it alone and watch it?
Absolutely. Absolutely. In fact, that is the first line, assuming that it's not exceptionally large. But frequently it's found as an incidental finding. People get a CT scan for some other reason or an X-ray that shows maybe the aorta is a little enlarged. So they get a scan that shows they have an enlarged aorta. We will do repeat imaging to see if that aorta is growing. If it's growing at a faster than expected rate, we may recommend surgery. But if it's staying stable, especially in a high-risk patient who has a lot of medical problems, we may opt just to observe the aorta.
Now, what would prompt surgical treatment, and what does that treatment look like?
Rapid growth of the aorta or anything greater than 5.5 centimeters meets criteria for surgical intervention. If it's 5 centimeters and in an experienced aortic surgeon's hands in a center that does a lot of aortic surgery, we may recommend surgery earlier.
So what does surgical treatment look like specifically for an aortic root aneurysm?
The aortic root is a really complex structure. Like I described, it has the aortic valve and the coronary arteries. So it does not have a good minimally invasive or endovascular through the groin option yet. People are working on developing techniques to do that, but it's not widely available. It's only at a few select centers. So as of right now, the mainstay is real surgery through the middle of your chest. Have to go through the breastbone to do it. And there's 2 options. If it's really, really large and the valve is really diseased, then we just replace the whole thing. We cut out the entire root, the valve, and then we put a new one in, and then we sew those coronary arteries back into it. If the valve is not really diseased, or if the root isn't overly large, we can do what's called a valve sparing operation where we save the valve. Because theoretically, no valve that we've made with technology is better than the valve you're born with.
Yeah, so is that why surgeons hope to do more valve sparing than they do mechanical
The
valves?
goal is always valve sparing if possible because it will last longer.
So if you do have to replace the root, what are your options?
Well, there are several different options. If we're doing just a standard aortic root replacement, there is a mechanical valve and a tissue valve. The mechanical valves are mechanically designed to last greater than 100 years. The downside is that you have to be on the blood thinner Coumadin, and specifically Coumadin, for the rest of your life, because the valve is at risk of developing clots on it, and you can have strokes or the valve can become dysfunctional. So mechanical valve mechanically lasts forever, but you have to be on a blood thinner, and it makes a clicking sound every time the heart beats, which some people say, I could never tolerate that. That other option of the root replacement is a tissue valve. So tissue valves are made out of, usually what we use is bovine pericardium. The tough sac that surrounds a cow's heart is fashioned into a new valve that looks like a human valve. And that valve is a great valve, but it has a lifespan. It lasts about 10 to 15 years, and eventually you will most likely need something done to that valve. There are some other options that are valve sparing that are not, they don't require an entire root replacement. So a valve sparing root reconstruction is an option to valve or root replacement.
And what does that look like?
So that there are three major different surgical techniques for that. The most common, widely known, is called a David procedure, where basically you cut out the diseased portions of that aortic root, but leave the support structures of the aortic valve and the coronaries, and you sew that into a new graft. So the patient's valve, support structures of the valve, and coronaries are sewn back into a graft. So they still technically have their valve, but it's no longer aneurysmal in the root. The other option is something called a Ross procedure, where you take the patient's pulmonic valve, which is structurally similar to the aortic valve. You move that whole structure into the aortic root position, and then you put a cadaver pulmonic root into that position. The procedure I do, that I was trained to do at University of Florida, is something called a Florida sleeve. So it's similar to a David procedure, where the patient retains their own aortic valve in the native position. We basically just buttress the aortic root with a graft. So it's basically, it looks like the same graft that we would use to replace the root, only it doesn't have a valve, and we sit it over the patient's root and affix it to the heart to keep that aneurysm from growing or becoming a problem.
Why do you prefer that procedure?
Technically, it is much faster, a much simpler operation. So it gets the patient on and off the heart and lung machine much quicker than if you have to do a David procedure. The David procedure requires a lot of sewing to resuspend all of the support structures and to reimplant the coronary buttons where those coronary arteries come out, whereas the Florida sleeve is basically just putting literally a sleeve around the root.
And you did mention also the Ross procedure. Are there any risks associated with using that cadaver?
One of my mentors used to say the Ross procedure is a great procedure, especially in children. But when we're talking about adults, there are a lot of surgeons who feel like when you do a Ross procedure, you take a 1-valve problem and turn it into a 2-valve problem, because the pulmonic valve is designed to live in a low-pressure system. So it may eventually degrade in the aortic position because it's a high-pressure system. And then when you use that cadaveric graft, it will eventually calcify and become dysfunctional, and so they will eventually need some form of an intervention on the pulmonic valve. That is typically done through the groin. It doesn't require going through the middle of the chest again, but it is another procedure.
What happens then if a patient has valve dysfunction in more than one valve when you get in there? It's more than, say, 2 or more valves when you go in, if you think you're just doing a Florida sleeve on that aortic valve.
Usually that's not a surprise. We have an echo or an ultrasound of the heart that looks at the function of the valves before we get to the OR. So we've been able to talk to the patient about that. But sometimes it does happen where you're surprised in the operating room and go, oh man. And it's just like any surgery. The more you do, the higher the risk. So the more valves we operate on, the higher the risk of needing a pacemaker after surgery, the higher the risk of heart failure after surgery. So when it comes to the heart, less is more sometimes, which is why also if there's more than one valve that's dysfunctional, we try to preserve or repair the valves as much as possible.
Is there ever a time where you're maybe using like the Florida sleeve to keep that valve, but then also might have to replace another valve?
Yeah, for sure. Absolutely.
Compared to a regular open heart procedure, if they have more than one valve that has dysfunction, how does treatment and recovery differ?
It really is patient specific, and it depends on how that valve is dysfunctional. In what way is it dysfunctional? Meaning, is it leaking a lot, or is it just not opening enough? Because those two different methods of valve failure have different post-op courses. So basically, it's just looking at the patient and really balancing volume status. Are they dehydrated? Do they need more fluid? Do they need medicine to help their heart squeeze or not? So sometimes when you have more than one valve, you wind up keeping the patient in the operating or in the ICU for more than the standard day that we keep them in the ICU after a single valve operation.
Can you talk a little bit about the importance of cardiac rehab for these patients after they have this procedure?
I cannot understate how important cardiac rehab is. In fact, I always encourage my patients to go to cardiac rehab. So cardiac rehab is a program that exists after the patient completes surgery. So they've had their surgery, they finished their hospital course, they may or may not have needed some inpatient rehab before they go home. And then they go home, home health is visiting them, and they come see us for their follow-up appointment, usually 2 weeks after they're discharged. And at that point, we start talking to them about starting a cardiac rehab program. And it's an outpatient program where they can be around other patients who have had heart surgery. So it's really helpful, one, so they can learn how to progress and build their stamina back up, but also there are a lot of psychosocial effects of heart surgery. It's a real existential crisis. It's a big deal to have your heart operated on. So it's helpful for patients to be around other people who have been through it so they can kind of compare notes and say, oh, I'm not doing so bad, or I could be doing better, So it's really important for patients.
How do outcomes improve for patients who are able to seek specialized heart programs in high volume centers like here at SMH?
So the Society of Thoracic Surgeons has released our recommendations, guidelines for aortic surgery. And basically what we have found is that high volume centers have better outcomes, lower mortality, lower complication rates, lower strokes. So being seen at a center that does high volume aortic surgery is clearly better for the patients.
And you have access to surgeons like yourself who might do a different procedure or give you different options.
More specialized operations, and also a better, more mature team. We don't function in a silo, although sometimes it feels like it. Cardiac surgeons, cardiologists, vascular surgeons are all very much involved in the care of these patients.
Understood. Is there anything else you want to add about this procedure or about aortic root aneurysm?
It's a really complex subject. Yeah, it's a lot of fun though.
Dr. Walker, thank you so much for joining us again.
Thank you.
And as always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.